Hi guys, thanks for having me here. My name is Constantine. I'm a PGY5 at the University of Connecticut. I'm here to present about predicting risk in patients undergoing diverticular resection for DVTs and PEs. I have no disclosures. As we all know, venous thromboembolism remains a significant source of morbidity and mortality in hospitalized patients. It's about 900,000 cases in the US per year, with an estimated cost of about $10 billion to the US healthcare system annually. In the colorectal world, at least, when discussing VTE and VTE prophylaxis, there's a large focus on patients with high-risk comorbidities like inflammatory bowel disease and cancer, and there's a large body of literature to support prophylaxis both inpatient and outpatient in these populations. When we look at patients with diverticulitis or patients undergoing resection for more benign conditions, there's not a large body of literature characterizing risk in these patients. Most institutions rely on a similar paradigm to manage VTE risk as laid out by the ASCRS guidelines. The first step is identifying high-risk subgroups. The second is inpatient in-hospital prophylaxis. And the third is plus or minus outpatient prophylaxis. Our goal here was to help clinicians have a low-effort, low-cost tool to identify patients that are at high risk for VTE that are often neglected by current practices, which addresses high-risk groups like colorectal cancer and IBD. So we did so using the NISQIP database. We looked at all diverticular resections filtered by both ICD-9 and ICD-10 codes and CPT codes between 2006 and 2017. Ultimately, we included about 83,000 patients with an event rate of about 1.6% for both DVT and PE combined. Using this prior literature review and our own clinical experience, we generated a list of variables of interest that we thought contributed to VTE, and using this, we did a univariate analysis to find significant predictors. We included these significant predictors in a multivariate logistic stepwise regression model, ultimately isolating 7 independent predictors of VTE in this population: age, ASA class, dependent functional status, perioperative steroid use, wound class, emergency surgery, and insulin-dependent diabetes. Relying on some of our statisticians for support, we used this multivariate regression model to generate a risk estimation model. The technique is based on that used in this Framingham study, which estimated in-hospital mortality following PCI interventions. And from this, we generated a risk of VTE per each cumulative score for each patient in the database. This was our ROC curve generated from a multivariate logistic regression with an area of the curve value of 0.64, which is satisfactory. This is a good summary slide of our model included here. On the left-hand side, you see our 7 independent predictors of VTE, each with their assigned score based on their weight in the model, ranging from 1 to 4. And then for each patient, based on the presence or absence of these risk factors, we calculated a cumulative score and then correlated that to the estimated risk based on our model. So the value in this is it allows us to compare our patients who have diverticular resections to more traditional high-risk groups like IBD and colorectal cancer. These groups are usually the groups that go home on some sort of post-discharge prophylaxis protocol. Current literature says the risk for these high-risk groups are about 1% in 7 days or about 3% in 30 days. And looking at our risk estimation model here, that correlates to about a score of 6 or greater on in our model. Therefore, we would recommend any patient undergoing a diverticular resection who scores a 6 or higher on our scale may warrant post-discharge prophylaxis, given that they have the same 30-day risk as patients who are traditionally thought to be high risk, like colorectal cancer and inflammatory bowel disease. So in conclusion, I'll keep this short, but VTE is a significant source of morbidity and mortality, and we think that there's a neglected high-risk group of patients who don't have cancer or inflammatory bowel disease that can benefit from post-discharge prophylaxis. Thank you.